Welcome to the Reverse Mullet Healthcare Podcast from BP2 Health. Today we are talking with Matt Miller, Chief Growth and Development Officer for Connections Health Solutions, about the importance of care coordination across the healthcare system. But first, why are we here? And who are we? And why did we name our show the Reverse Mullet Healthcare Podcast?
Well, because we want to be relevant and informative, but we also want to be entertaining and have fun. So it's like party in the front and business in the back.
Yes, I have to do the hands.
So like a mullet, only reversed.
Yeah, right, exactly. We are your hosts, Dave Pavlik,
Justin Politi.
Ellen Brown.
We are passionate, innovative, and collaborative and are committed to solving our industry's most important issues together with our clients. We have a combined 90 years experience.
And that doesn't even include Matt. So
No, so we'll be
I think we'll be well over the
120,
century mark, which makes us sound really old.
In each episode, we will dig into a hot healthcare topic and dig into each other a little bit.
Be gentle on me.
No, ever. Nope. I'm the only one that you have to be gentle with.
But you know Matt well enough, we could dig into him some too.
Yeah. So without further ado, wait, is there like a sound effect for this? Justin's so excited. Yeah, like you got to tee yourself up on this. Okay, all right. Here's Justin.
Here's Johnny. No, I am super excited.
Are you really?
You had your favorite guest and topic the last go around.
Yes,
with
I
Carter,
did.
Right?
I did.
And you were walking
about
on
food.
You were walking on air. Then now I get to have mine today. Super excited to have Matt here. But I guess one of the things we always have banter to start, right?
Yes,
and so
we
one
do.
of the things that I was thinking about
Party in
is
the front.
preparing for the episode was part of me wishes I could go back in time and go to the neighborhood that currently lives in, right? Because I know I'd be that neighbor.
You would.
Oh, I'd be at your house. I'd be watching football games. We'd be doing barbecue challenges, and we might even invite you if you were around.
Do you have a man crush?
He totally has this is like his bestie that he wishes
You might invite me too.
I might invite you, maybe.
Okay.
But
Maybe.
we'd invite Ellen would be invited, but you know that she'd go home by 5 o'clock.
Yeah.
Ready for bed.
Get ready for bed.
Yeah.
Definitely.
Yeah. Maybe I'd stay till like 7.
Maybe. Right.
So yes, Matt, you are clearly a favorite. Like we all have our favorites, and there you go.
Well, it's a pleasure to be here. It's an
Good.
honor, Justin.
Yes. Super happy. As you can see, I'm glowing.
Keep a lookout for homes for sale.
Yeah.
Keep him
This could
posted.
get this. Yeah.
But a little background on Matt. He leads the strategy, the organization's business development and growth strategy. And prior to joining Connections and where I first worked, or where I first met Matt, he served as Senior VP of Behavioral Health at Magellan Healthcare, where he led the company's behavioral health business line. He has more than 25 years of experience in the healthcare industry, focusing on strategic planning and growth, operations, business development, and provider delivery system transformation. While at Magellan, Matt served in progressive leadership roles in operations and network management, provider relations and business development, including Director of Business Development for Magellan's Public Sector Business Unit, Vice President Public Sector Provider Network, where his focus was on Medicaid and public sector delivery systems, National Vice President, Behavioral Health Network Management and Operations for both public sector and commercial network management, VP of Operations for Magellan's Public Sector Programs, and Senior VP Public Sector. Impressive career. Growing sweeter each season as you slowly grow old. Do you get...
Walk on the ocean?
Yes.
Whoa.
Oh Toad the Wet Sprocket.
Toad the Wet
Can you?
Sprocket.
Can either of you sing that?
Walk on the ocean.
Oh.
Yeah.
Step in.
I
had to layer in a 90s song.
I didn't get
reference.
this
It
one.
always does that.
You even
goes
said,
zing
"Does someone
right
get?"
on
Yeah,
that.
went right over. And so much goes right over my head. I'm
Well-
always focused on like the. Yeah.
Well, welcome, Matt. As you know, we always like to start with a little party in the front. So apparently, you have a super competitive neighborhood that
Justin wants to live
that
in.
Justin wants to live in.
Yes, which is a little. I think it might be a little creepy now. I don't
Yeah,
know.
I know.
Like I think maybe we've crossed the line of.
Stalking much?
Yeah.
When it comes to Halloween costumes,
be
at
there
the
next year
annual
with
the annual Halloween costume contest, your motto
Going to
is
show up randomly.
your motto is go big or go home. Can you tell us a little bit about this contest and the costumes you've sported?
Sure can. Well, first, I guess thank you for having. This is great, and congratulations on the podcast.
Thank you.
It's fantastic.
Thank you.
Big fan, first time or long time listener, first time attendee.
Yay!
So appreciate it.
Thank you for coming.
Yeah. So Halloween, yeah. So we have the neighborhood that Justin is going to move into. Probably be at the party this year. Great neighborhood, have fantastic neighbors and friends. And neighbor down the street has a big Halloween bash. And the first year we were new neighbors and didn't really know what to expect. And we kind of showed up ho-hum costume-wise and realized that we had to up our game. So
What were you?
the first year...
Forrest and Jenny?
No, that was this
Hanson
last
Brothers?
year. That's been done. But the first year we really got into it, three of my good friends in the neighborhood, we came as Kiss, full costume.
Oh, outstanding.
So
Outstanding.
we brought the show down, and we just had to up our game every year. So sometimes we do it as a group, sometimes as couples. And as you said, this last year was Forrest and Jenny with my wife and I. So we had a blast with that as well.
We got to get a picture of that.
Yeah, but wasn't there like some really epic middle? I thought you told us a story about like showing up at the right? Am I missing this?
So before going to the party, we were at a pre-party. And,
okay. So this is really a thing.
This is a
Pre-gaming.
thing.
There's a
This is a
pre-gaming
thing.
for
They
a
were
Halloween
pre-gaming.
This
party.
is a thing, and my neighbor friend had a riding lawnmower, and we thought it was a great idea if I make an entrance to this party on a riding lawnmower and full Forrest Gump attire, and it was a good one.
That
so
is-
it'd be tough to one up that.
That
next
is
year, but
outstanding.
It's
we're
like
already
Forrest
planning.
Gump mixed with Can't Buy Me Love.
It's always something with you. You've always got the sayings. So, all right. So we also learned that you and your family love the beach, that you're big beach enthusiasts. And so, Justin lives on the west coast of Florida, and I live on the east coast of Florida. And so we sort of have this running debate. I think my water is better because we get that we're the closest beach to the Gulf Stream, so we get that blue Caribbean water. He's rolling his eyes at me, but we don't get red tide over there.
No,
like
you don't.
do.
That is-
okay?
right.
So I'm just saying there's a difference in, okay? So
But the clarity of the water and the beach sand in Siesta Key
no,
is
the clarity
second to
is
none.
clarity's on par. The clarity is on par. It is. You got to come over. We
There's
got to
gonna be
get
a
together
throwdown.
more.
There's going to be a throwdown.
There is. So, but anyways, so clearly, we're all vitamin D worshipers because I understand. So, what are your favorite beaches? And I think there's continental and then outside of the continental U.S. So, I'm curious.
Well, so I grew up in Minnesota. I'm not sure you guys knew that, but I grew up in Minnesota, so completely landlocked.
Near a lake or
Not
no?
near a lake, no.
Okay.
Spent a lot of time on the lakes, but had good fortune of being able to go to Mexico, Riviera Maya a lot as a kid with parents, and just kind of fell in love with beach life. And after we moved to the East Coast, after I moved to the East Coast and we had kids, so quick story, we went on a Disney cruise, and we combined a Disney cruise with Disney itself. And this is the first time we took the kids to Disney. And after we got done with that vacation, we said to the kids, would you rather go to the beach, because we stopped at a beach on the cruise, or would you rather go to Disney?
Did you go to Castaway Cay?
We did, yeah. And they said, we'd much rather go to the beach. So that was music to my ears, and never have to go back to Disney again, at least not with children. I'm happy to go back now. But yeah, we've been beach people ever since. My wife's from the East Coast. We spend a week with some of those same neighbors at a little slice of
Don't
heaven
tell him
called-
where. Don't tell him where. He'll be there. Sorry. Just warning you. No, I'm just kidding.
South of Virginia Beach, Sandbridge Island.
Sandbridge. I know
Yeah,
Sandbridge.
Yeah, we've talked about Sandbridge. So yeah, we spend a week there, and then at least once a year we try to get to the Caribbean somewhere. So love the Caribbean, Jamaica, Riviera Maya. Yeah, so any beach is good.
So I'm just going to throw out for you. So these guys know, and you know from last summer when we were working together, I love to travel. And I will tell you, Corsica and Sardinia, islands that you should seriously consider if you like the beach. So, and the cool thing is Corsica is French. Sardinia is Italian. So you get to, and both of them have, like, you feel like you're in a French country or, on a French island. You feel like you're on an Italian island, and you can take a ferry between the two. And it is very cool. And so my description of them is it's like being in Tuscany with the Caribbean. Without the crowds. Now, don't go in August, but like June, July, it's phenomenal.
Okay, I'll get those names from you, put them on the
Yes,
list.
I will. I
Thank
will.
you.
So, anyways.
Do you have
all
to
right.
speak with a French accent on
No,
the French
don't
one?
do
and
that.
Italian
Don't
on the-
stop now. Please stop. Okay.
Yeah, it sounds like Pepe Le
That
Pew.
was just not.
I don't
I don't know
how
what
kept
that
it.
was,
I
but
don't
it
know what
didn't
was
go
either.
well.
Yeah,
But it was nice attempts.
can cut that.
We'll edit it out.
No, we don't need to edit it out. That's what makes the show fun. Some people say.
All right, so let's
I guess
jump.
we have to do. Wait,
we have-
do that sound effect.
Which one? This one?
Yeah.
So it does remind me of the Muppet Show.
It's a little bit between the Peanuts.
Because we're
and the
sadly
Muppet Show.
transitioning from the party in the front to the business in the back.
Yeah. Yeah.
All right, so let's jump into our topic for today, which is really going to focus around the need for improved care coordination and care management. But before we delve, into that in particular, really want to talk about where you're currently at with Connections Health Solutions. And for our listeners who haven't heard of Connections, the model they provide is 24/7 mental health crisis care with no exceptions and no judgment. At each of their centers, they have resources and teams that provide personalized treatment and care for people with urgent and immediate mental health needs. Now, Matt, can you give us a little bit of a background on Connections, the model of care itself, and how you're working to help divert unnecessary utilization from emergency rooms and inpatient settings to Connections facilities?
Yeah, absolutely, and thank you. So you went through a long history that I had on the payer side, 22 years. You make me feel really old, so thank you. And we did a lot of great things there on the payer side, especially work that we did in the public sector Medicaid business. And after, again, a long career there, I wanted to think about what's next and be able to have more of a direct impact into the work that I was doing in the company that, to work for was doing. And so came across Connections, which interestingly I knew of Connections but by another name. So Dr. Chris Carson and Dr. Robert Williamson founded Connections. They were the co-founders, and actually the model of care, which has come to be known as the 23-hour observation model of care, was kind of created out of necessity by Dr. Carson when he was actually in Texas in the 90s. And, let me know if you've heard this story, but someone boarding in the ER for a really long time, no inpatient bed available to go, sits in the ER for 2 to 3 days, finally gets transferred and really doesn't get treatment until that 4th day. So that was the problem in Texas in the late 90s. That's still the problem we're having today throughout the country. When I was on the payer side, this was actually something that I was trying to do in any community, in any state that I was doing business in. And it was a level of care, if you will, that just didn't exist. And it still doesn't exist in a lot of communities. So it was comfortable to me. And I knew that, there was some tailwinds in the space from a regulatory perspective, from a licensure perspective, to really jump into this and help to grow and expand the model. So we are, as you said, 24/7 behavioral health, mental health, or substance abuse, anyone at any time, regardless of demographic, regardless of insurance. It effectively serves as an alternative to the ER, an alternative to long-term inpatient hospitalization, and in some cases, alternative to jail and detention. So yeah, that's the history of the organization, and we'll get into a little bit some of the expansion as we move forward.
Super interesting background and model there. With the overwhelming volume of mental health crisis cases nationally, you must be getting approached by every state. I would imagine, right? Or federal agencies, right? To bring your model into.
It's interesting. No one's ever said this was a bad idea, in my time there, and even,
right.
Beforehand. So I started a little over 2 years ago, and at that time there was 6 states that had regulation or legislation related to crisis care, to the type of model that we have. Today there's more than 30 states that are in the process of changing regulation or legislation to allow for this type of model. So
And what period of time has it shifted to be 30 states? Like that's
In the last 18 months.
wow.
Yeah.
That's
crazy.
amazing.
Pretty
so it's
significant. Catching on fast.
So you certainly saw some tailwinds.
Definitely some tailwinds. There are a lot of tailwinds coming out of COVID. I mean, if there's anything,
Okay.
anything good that came out of COVID, other than ripping the bandage off of telehealth, it's a heightened emphasis on mental health and on behavioral health. So yeah, states are looking at this. Local municipalities are looking at this. Counties are looking at this really collectively to solve the same issue, and that's to provide more access, better care, and better outcomes than what the alternatives are today.
Very cool. So recently, PBS did a segment on the Arizona system for handling crisis care, 988 availability, which I also want you to give us a little bit about this 988 availability and the unique approach the state takes, and highlighted the role that Connections is at play here. And we'll provide, now Dave, I feel like we say this and then we have to figure this out, is we will provide a link to that PBS segment to our listeners in the show notes.
Yeah, absolutely.
All right.
I just watched it. It's really well done.
Yes.
It is actually, yeah.
But Arizona feels like it's much further ahead from other states. Can you share why you think that's the case, and just give us a little bit more background on that?
Yeah, I mean, Arizona definitely has been ahead of other states when it comes to crisis care, and I think the what they did originally was blend funding, blended SAMHSA block grant dollars, blended Medicaid dollars, non-Medicaid dollars, county-based dollars, to ensure that the uninsured were cared for, and there was a path to that to make programs sustainable. I think, like you said, that PBS piece just came out, I think, last week, and talks about some of the really good things that are available in the Arizona system and the crisis system, and areas for need for continued improvement. It's evolved over time. Crisis services have evolved, expanded, moving past that beyond the 23-hour observation model and into crisis stabilization. As relates to SAMHSA, 988 is we're almost 18 months into 988. Maybe not that far, but it's definitely a year anniversary of 988 launching. If you don't know what 988 is, please research it. Everyone should know what the national hotline for suicide prevention.
Yeah, it's like 911, but I don't remember the stats exactly, but in that documentary they talked about there was previously an 800 number or toll-free number at National Suicide Line,
Yep.
and the number of incoming calls increased by huge amounts when it went to 988. So just simply changing from an 800 toll-free to a 988. I don't remember the
I feel
numbers,
like
but it was
people
staggering. The stats were amazing.
Even with it, I still feel like people don't know about
No, I
it.
would
They don't.
totally agree.
It hasn't been rolled out consistently across the country. There are, states and counties that have had a dedicated crisis call center in the past, quickly adopted 988. But there are still some challenges that I know SAMHSA is actively working through, and others are working through, to make sure that it's rolled out, that there is no confusion, like when you're calling from a cell phone number that has a prefix of Nevada and you're actually in California, that they know that you're in California, not Nevada. So they're working through some of those details. And I think, there was a planned rollout of 988, and SAMHSA has done a fantastic job with that. And they're also, it's part of the kind of this three-legged stool around crisis. So someone to call, 988, someone to respond, which would be mobile crisis, and then some place to go. And that's where organizations like Connections come in, is some place to go, without judgment, without stigma, without having to go to an ER, without fear of going, being detained and ending up in jail because of a mental health or behavioral health issue.
So can you explain how you work with or how Connections works with first responders in each community?
Yeah, very, very closely. We consider them a key constituent, and I say that specifically. We have a large percentage of people that are transported to our facilities via law enforcement or other first responders. And I say transport because they're not in custody. Sometimes they're in custody for their own safety. But when they're coming into our facility, we have peer supports that will meet law enforcement at a back door and take the cuffs off an individual, that they know that they're entering into a treatment environment, not a law enforcement environment. So working collaboratively with first responders, and it kind of changed the culture of how law enforcement responds to behavioral health emergencies is really important to the work that we're doing in Arizona and elsewhere.
So I'm going to have you step away from Connections for just a second, and we're going to go at a little more personal level about what you think is needed to affect real change within the marketplace and the healthcare system as a whole. Can you give your thoughts and opinion on that?
Yeah. You as we all have been you're in healthcare for a really long time, you think you got to figure it out. As we all laugh, right?
Bump.
I know, right?
Yeah.
Wait,
That's a good.
there's-
There you
Yes,
go.
there you go.
All
You got it
On
right.
cue.
And there's so much that, can be done better in healthcare. And I think, recent experiences, you think about that kind of first and foremost. So care coordination, right? Especially with an aging population. Systems don't talk to each other. Health systems don't talk to each other. IT systems don't talk to each other. It's tough, especially in large rural parts of the country where healthcare desert, healthcare shortages, and just coordinating care generally for a consumer who's dealing with the healthcare, especially behavioral health. It's tough to coordinate care on behavioral health, but coordinating care generally, just to have a better system, a better solution in place for that to help the consumer navigate the healthcare experience better. I mean, healthcare is for the consumer, right? I mean, and sometimes I think we forget about that and what it's really for. If we need to put the focus on the consumer, we're going to get better health outcomes.
But we had the pleasure of working with you and really got to dive into, I really enjoyed learning not only the model, but the value proposition of the model. And when you talk about care coordination, we think about primary care and how it integrates in with specialty care and then acute care. And behavioral sort of is this ancillary. And what we realized, and I think, like you said, COVID really hit home, that behavioral is part of it all. It's not an ancillary. It shouldn't be stuck in a corner over there, which is what we have effectively done. And I just loved how the model that you represent, that you're building and putting in different parts of the country, is it addresses behavioral at that care coordination level, and it meets people where they are. Because so many times things can be de-escalated really quickly just by somebody getting the right medication or just having someone to talk to. And so the idea of having a physical location where somebody can come and just sit and be heard, like you said, without judgment, and that there are different levels of care just for a behavioral health issue, right? Versus you come in, like you said, and I don't think people really, I certainly didn't understand the need for care coordination at a behavioral health level on its own, right? It's still integrated in. And so when we talk about care coordination, I know we're going to talk about broader care coordination, but I think it's really cool that you get to work in taking a model that was working in Arizona and now bringing it to other parts of the country to say, look, behavioral health is a huge problem for our country. It's a huge challenge for healthcare. Like Justin joked, I got my food discussion. He is super passionate, as you know, that's how you all met, about behavioral health. And I think it's really remarkable. And so.
Yeah, the behavioral health, I would put it in a different term. Behavioral health is a huge opportunity for the country, right?
Yep.
It is a problem that we haven't gotten it right yet. And I think that's the opportunity that's in front of us. Your point around the care coordination aspect. Someone comes into a crisis facility, and the goal is to stabilize and get that individual back to the community as quickly as possible. And that could just be an urgent care visit because they're on meds. They weren't not able to see your psychiatrist to get a refill.
Exactly.
It could mean a 23-hour, less than 23-hour stay just to stabilize what's going on, and really talking about not what the problem is, but what happened that you got here. And we're glad that you're here, but how can we help address social determinant of health issues, other issues that cause the crisis or whatever is going on, and address that head on, and then do the follow-up as well. We view ourselves as part of a system. We can't exist in a silo, and we have to work with all other organizations and providers in the system. And I think that's something that we do really well, and we need to do really well as we expand into new markets on really helping to use our position to help coordinate the system in a better way so that it's more accountable to the consumers who are utilizing it.
And I'll put a plug to all the payers, all the people on the payer side. We talked in the episode previous to this about the sides that shouldn't really exist, right? But joking aside,
Star Wars type analogies they're used.
It's like we could bring the lightsaber out. I wish we had that sound effect, right? Like that buzz noise. That's like a cool, very like.
Seems to me that there should be a connections facility in every community.
There should.
Doesn't it feel like that?
Well, I heard this, Matt's conversation about the borders in the emergency room. I know that happens in our local hospital all the time.
Well, your
especially
wife
on
works
the weekend,
there,
right?
So.
And there's borders. They're literally on a gurney in the hallway. They're not getting any treatment, and they're not getting any quick care coordination.
It feels third world, doesn't it?
Yeah,
absolutely.
But so I'm not an expert in this topic like you are, but you've often say, Justin, that it used to be back in the day that we had this. So why did it go away?
That's a good question. We didn't invest in those communities where these locations were. It became easier to push these individuals into the emergency room, and it's unfortunate that we didn't invest in those things. But I'm interested in Matt's opinion on on the dynamic.
So wait, because I lost my train of thought on the lightsaber.
Oh, I'm so sorry.
It's okay. You were right to take over the conversation because I had gone down a bad rabbit hole. But I am, and then I do want to go back to the question you posed, but if we can remember it, is value-based care is, I feel like, the opportunity, when we talk about opportunities, it is the opportunity to recognize this model of care delivery for behavioral health as part of care coordination at large. And I think that is one of the places that we have gone wrong. And I'll pose this working with you all really opened my eyes to the fact that we're big proponents, as you know, of value-based care. That is something that I'm super passionate about. It's a legacy item for me in what I'm doing. And so I really was blind to the fact that value-based care largely ignored things like behavioral health, right? And like we've talked about before, we've carved those things out, and now we've kind of given the money away, and we need to figure out how to bring the money back together, which is right. So my point was I was trying to plug the payers to say these models need to be recognized in value-based care for the inherent value that they bring beyond just the incidents, the services, those that come in your door.
That's an excellent point.
I think payers get it, right? I think conceptually they get it. I'm a recovering payer. I think the industry gets it, right? But there has to be more of an emphasis on it. If you can think about it from many different aspects, but if you think about it just from a top line dollar aspect of an episode of someone in a traditional model, as we think about traditional, you're really not having a good day.
So walk us through that, because I do actually think it's a good education. We've kind of hit on it on the periphery here, but walk us through what the alternative to connections is for the healthcare system, because there are a lot of people that listen to this that don't have that background.
I mean, someone is suicidal, homicidal, really not feeling well, something's going on, and they make the appropriate right call and say, or hopefully they're calling 988 now, but previously they're just going directly to the ER. Where else to go, right?
Or they're brought, right?
Or they're brought to the police,
or
right?
they call 911, law enforcement comes out, and law enforcement is bringing them to the ER, bringing them someplace else.
Or the family or something,
right.
Yeah.
So I don't know off the top of my head what the average boarding time, and it varies by community, but there's always someone boarding for a behavioral health issue in an ER.
Meaning that they're just staying, again,
They're waiting for a bed to open up. They're waiting for medical clearance. They're waiting for something. That's one of the things about our facilities. We do medical clearance. You don't have to go to an ER to be medically cleared to be admitted into one of our facilities. But they're waiting for a bed to fill up. There's a shortage of beds. There's a workforce issue, right? The shortage of beds. And so they're boarding for 8, 12, 24 hours, not getting active treatment, and then admitted to an inpatient facility, probably not getting active treatment until day 2. So you're three days into a crisis, and sitting in an ER is not a great place for anyone, but someone that's experienced a behavioral health issue. So the alternative is you come to a crisis facility. And your point early, Dave, about it's happening in the hospital where your wife works. It happens every day, and there are other alternatives to large scale programs like ours. There are psych emergency services. There are other there's empath units that organizations, largely rural community hospitals are looking at as an alternative to make it a more cost effective alternative for those rural communities. But yeah, so the ER admission, cost to the healthcare insurer, inpatient admission, cost to the healthcare insurer,
and it's not even the appropriate place.
And it's not the appropriate place.
There's nobody there.
Readmission rates aren't that great, and that's when the care coordination aspect comes in. Is really what is going on? Are we really addressing what caused the crisis and the individual come in versus call your PCP and follow up in 7 days, right? So the alternative is to get effective, immediate treatment right away. So models like ours, we're a medical model with full complement of medical staff that are treating the crisis as well as treating the psychosocial issues as well. We have a lot of techs, a lot of peers that support our program. So we're really addressing what caused the individual to come in and how can we help that not happen again. It will, and we'll get, we continue to work with that individual and work with the outpatient provider or other community supports to make sure that they have the support that they need to remain in the community.
So Dave, are you going to ask your question? One of the questions we always ask.
Yeah, sure.
Maybe we can sing.
Yeah, no, we always.
Matt's old enough.
You
We
probably
gets the
know.
reference. So.
Right. the old commercial, like to buy the world a Coke.
In perfect harmony.
Like
I remember that commercial.
Yeah.
So
Thanks again, Justin, for writing on my name.
now you've got an earworm for the rest of the day.
Yes.
What would be your buy the world a Coke moment
For healthcare.
For healthcare.
Make it easier for the consumer. And anything that could be easier for the consumer, especially vulnerable populations. In the lens of care coordination and care management, how can we make it better? I think there's a lot of fear about AI and what it's going to do to healthcare and what it's going to do to a lot of industries, but healthcare in particular. And I know enough about AI to get myself in trouble when talking about it. But being able to link certain healthcare systems. And I recently had an experience where, individuals was getting treatment in one healthcare system and received outpatient services in another healthcare system. Those systems didn't talk to each other because they didn't have the same medical management platform, the EMR, and they just didn't talk to each other generally. And that just puts a patient in a bad situation of really trying to navigate on their own. And I think for those of us, just speak personally, been in healthcare for a really long time, you think you got to figure it out until you are in the depths of actually trying to figure it out, and then it becomes a lot more eye-opening.
Absolutely. So you made me think, and this is a guest that we're going to have probably sooner than later, but there's a company you should look into it called Lirio, Lirio. You might have heard of them, but I think they're an interesting, when you talk about AI and the need for, again, behavioral health and behavior in general, they have an interesting approach that sort of new entree of being dangerous in AI. Like, I think that's an interesting, I'll be very interested to see where Martin and company go, because I think it's a great concept.
Right.
But so last question, if you could leave a legacy in healthcare or feel like you made a big difference, what would it be?
Legacy is a big term.
It is, but that's why this is why it's our passion project, because it's like, let's talk big, real.
I'd probably answer that maybe 3 ways, if that's okay.
right.
One is anything that I can do or the company I'm working with can do to continue to reduce stigma around behavioral health, mental health, and ultimately, if there could be a legacy, it would be someone saying, the same way I've got to go to my PT appointment, right? Broke my arm, going to PT, I've got to go to my PT appointment without shame, for someone to say, need to go to my behavioral health appointment without shame. So as a country, for us to be able to get there, and if we can influence legislation, if we can influence regulation to be able to allow for new innovative services, the behavioral health delivery system and services hasn't really changed. Probably the biggest change was deinstitutionalization, and COVID helped just from a recognition standpoint that mental health is real, and we need to talk more about it. We need to be more accepting of it. So getting it to be more commonplace.
And not as much of a stigma, right?
Not as much as a stigma, and not being afraid to talk about it, and having it be, it's an illness just like pneumonia is an illness, right? And get treatment and be able to treat it as an illness and not as something, behind closed doors.
I would actually, I will sort of throw I don't want to say counter because I agree with you. But I think this gets into just health in general. Yeah. We talk about our physical health and the need to put energy towards it, right? What we eat, how we move our bodies, our sleep. And I think our mental health is just as imperative. And I think if, as a society, we talked more about how to keep our mental health at the top of its game, it would be a real game changer for so many different layers. I mean, it would remove stigma. It would allow us to be much more proactive. It would allow us to be honest with each other of, I'm just not feeling it today, right? I'm a little cranky, I'm whatever. And right. And like today, whenever I got off the plane and I
Snippy. You were snippy.
I was snippy
She was
today.
snippy.
I was snippy. I don't know why, but I didn't get enough sleep.
She yelled at me.
But you get what I'm saying, Matt.
Yeah.
Like I think there's such an opportunity I hope we have a lot more around behavioral health and mental health on our podcast, because it as much as I love food and could talk about health like that, I think the behavioral aspect and mental health in general is just largely not discussed and not recognized.
And the third thing I was going to mention comes back to that, right? So better mental health is going to be better overall health, which is better to the healthcare system, better to the healthcare dollar, right? There's a ton of not understood costs related to mental health, right? Whether it's workplace, whether it's just healthcare costs generally. If we're taking care of mental health, behavioral health, we're going to take care of the rest of the healthcare costs. And I think from a legacy standpoint, there's not a lot of value-based care in behavioral health, very little. All right, so that's one of the things that we're going to try to change. Connections as we continue the work that we're doing across the country and expanding is really focusing on the value to the consumer, the value to the payer, and ultimately the value to the entire system. Because we talked about law enforcement, we talked about other community stakeholders, being able to address a healthcare issue that is directly getting better outcomes for the consumer in a much more cost-conscious way is good for the healthcare system.
So I'm going to go off script real quick.
Because I haven't done that today.
Where did your passion for behavioral health, personally, where did it come from?
Most of my family's in healthcare. My mom was a LPN and then worked in a county-based WIC clinic. Yep. So I went to school, graduated with psychology and criminal justice. My eyesight was really crappy, so I couldn't get into the FBI. So I kind of landed on the delivery system side and had always done things from a community-based behavioral health perspective. So I got my start in more community-based behavioral health programs, partial hospital programs, group home programs. Actually, a crisis center, actually one of the first ones in Philadelphia, way back in the day. And as I as I moved into the managed care side, I think I didn't know what managed care was when I moved into managed care. It was, I was younger in my career and really kind of realized, gosh, I can glean so much for this from the administrative side and the payer side to then bring that back to the delivery system side. And so it's a long-winded way of saying it's just kind of been innate over the career.
That's why you guys are like soul brothers or something. You're like connected.
Like I said, I'm showing up at your house with the
Soulmates.
They are. They're like brothers.
I just have to figure out my outfit. That's my...
For Halloween.
I don't know.
You gotta go big.
You are forewarned.
Yeah.
He's been forewarned.
Yeah.
Sorry. Where what's Connections' footprint right now, other than Arizona, and where are you going, if you can say?
Yeah, so we're we've been operating for 15 years in Arizona. So Phoenix and Tucson, we see about 30,000 people a year between those two centers. That's a lot of people coming through the doors in Arizona. We're expanding to Washington State this summer. We'll have a large facility in Kirkland, Washington. There's a lot of great things going on in Washington. The state and the county are taking some really proactive steps to address behavioral health issues generally. Virginia, we're going to be launching in Virginia this year. We'll have 2 programs in Virginia, Northern Virginia, and then Pennsylvania as well. So Harrisburg will be our first program in Pennsylvania, and a lot of tailwinds behind us. And as you said, there's just a lot of people looking at this of a much more effective and better outcome alternative to what's happening today or what's not happening today.
Well, after talking with Dr. Elliott, our guest just now, I feel like Delaware is a perfect proving ground.
It's on the map, absolutely.
It needs to. It sounds like it's a perfect microcosm. So
Every state. We got to have one in every state.
we do need to have one
Every
in every
county.
state. So.
Yeah.
Well, I'm so glad you came, Matt. It's
a pleasure to be here. I'm so glad to be able to
It's
come.
fun to have a friend on the podcast.
Yes,
and so-
absolutely.
Yeah, I appreciate
And
your time.
Justin certainly feels that way. So. Sorry,
As
I
we-
got to give you a hard
we turn-
time. I can't.
I know. Hey, it's coming back at me.
It's you exactly. You
Yes,
dish it out at
yes.
me, so
Yeah.
I.
So I have to have thick skin. That's
Yeah,
right.
that's all right. We all
You
have
should
thick
have told
skin.
me this like 2 years ago. The house right next to me opened up.
All right.
No, you're glad. You're glad. So
I'm texting Shan my wife after this, and I'm like,
I told no. So we were joking about this because here in town, we're in Westchester, where we are. We're driving through town to get a coffee, and Justin's like, "This place is great. I could be like the mayor." He literally said, "I could be like the mayor here," and I said, "Yeah, but you can't endlessly sit in the sun and go to the beach here. That's the problem. So it would not be it." So, anyways, well, thanks again. I'm Ellen Brown.
I'm Dave Pavlik.
and I'm Justin Politi.
We are the partners at BP2 Health. Your best chance for real change.
As you can tell, we could talk about this all day long. Drop us a line through our website, bp2health.com. This episode is produced by Mainline Studios in Westchester, Pennsylvania.
Give Eric a shout.
Eric.
Yeah, give Eric a shout.
This
Not
has been a guest studio for us, and it has been fantastic. So.
Yes.
Yeah.
Thanks
All right.
again.
Thanks again.
Have a great
Thank
day.
you.